Oke. Ya, sudah jam 3. Saya kira udah cukup banyak peserta yang mulai masuk. I would like to check whether Kristiina, are you already here with us? Oh, okay. I
Yes,
can
I'm
see you there.
there.
Yes.
Can you hear me?
Okay. Right. But your voice is not as louder as last night.
Can you hear me?
Yes. Yes. Could you,
Is it loud enough?
yeah, quite. Not as loud as last night.
If everyone puts the loudspeakers on
Okay.
maximum, it might help.
Okay. Okay. That's fine. Thank you, Kristiina, since you already been here. So I think we could start the webinar right away. Okay. Let me get ready first. Okay. Untuk Bapak Ibu yang lain mungkin bisa kita mute dulu sementara. Saya akan buka dulu acara webinar pada sore hari ini. Selamat sore, Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Pertama-tama marilah kita panjatkan puji syukur kehadirat Tuhan Yang Maha Kuasa karena kita dapat dipertemukan di acara virtual meeting pada sore hari ini dalam keadaan sehat walafiat. Dan beruntung pada sore hari ini kita bisa berdiskusi bersama narasumber kita yang cukup jauh dari Helsinki, Finlandia, untuk sama-sama sharing tentang clinical coding audits ya. Perkenankan saya untuk memperkenalkan dulu narasumber kita pada sore hari ini, dan saya ingin menyampaikan juga kepada para peserta bahwa kita kita hanya punya alokasi untuk sekitar 100 orang saja dan selebihnya mungkin akan bisa mengikuti dari YouTube channel kita ya, YouTube channelnya CC Online. Jadi Kristiina, I also informed that we are live streaming also from YouTube channel of our channel Center of Coding Excellence. And let me introduce you first before your presentation will begin. Jadi narasumber kita ini profilnya adalah sebagai berikut. Ini dari beliau sendiri, saya hanya translate saja. Jadi Dokter Kristiina Kahur ini adalah Wakil Direktur Pusat Casemix ya, Nordic. Jadi Nordic Casemix Center. Dan juga Konsultan Senior di perusahaan konsulting FCG di Finlandia. Beliau juga bekerja lepas atau freelance sebagai konsultan sistem Casemix ya. Kristiina adalah seorang warga negara Estonia yang tinggal di Helsinki, Finlandia. Pekerjaannya berhubungan dengan evaluasi, pengembangan, dan pemeliharaan berbagai sistem Casemix dengan fokus utama pada sistem Nordic. Jadi beliau ikut dalam tim pengembangan sistem Nordic. Sebagai tambahan, Kristiina memiliki pengalaman yang ekstensif dalam hal monitoring dan analisis kualitas data dengan fokus utama pada penggunaan klasifikasi primer, jadi tentang coding juga. Dalam implementasi dan pengembangan program-program audit coding, dan juga dalam menyelenggarakan audit coding. Kristiina lulus dari Universitas Tartu, Estonia sebagai dokter umum, dan memperoleh Master of Public Health-nya di universitas yang sama. Kristiina merupakan anggota dari Komite Eksekutif Patient Classification System International, tempat dia bergabung sejak tahun 2010 yang lalu. Demikian mungkin profil beliau, dan kami waktu itu berjumpa dalam acaranya World Bank di RG meeting di Manila. Jadi di sana kita ketemu, dan I also invite some of our colleague that we met in Manila ya, Kristiina, there are Mr. Pandu, and then Pak Rocky, saya juga mengundang Pak Rocky, ada beberapa teman dari BPJS gitu. Jadi saya kira itu yang bisa saya perkenalkan. And for Kristiina, I would like to introduce you. There are now 44 participants here we have in this webinar. Some of them are a medical record practitioner in Indonesia in several hospitals. And then there's also the payer, the body of insurance, yeah, social insurance that is paying the social security, and then there are also academician, yeah, lecturer, and then we also have senior, what is it? Senior supervisor in management, Casemix management in the hospital, and then there's also other interest. We have Mr. Pandu from World Bank here, and also I believe we have from Bio Farma, Dokter Teki, and also a public health lecturer, and then I think that's it. So we have various backgrounds of education here that becoming participant in this evening, and so I hope we can share many things, and maybe we can also trying to figure out the next collaboration in the future, potential sharing knowledge in this field especially. And thank you for joining us today. So without further ado, I think it's your time to make your presentation. Would you like to do your share screen by yourself?
Yes, I start with my. So I just check once again if you can hear me.
Oh, okay.
Yeah. And I do I share my screen.
Yep. Okay.
So, selamat sore. That's so far all I can say in your language. And welcome everyone to this webinar. You made the introduction already and you went through my bio, so I'm not going to introduce myself anymore. And I would like to thank you, Lily, and also all participants, of course, to both. Thank you for inviting me and all participant joining this event. That's true that clinical coding, and actually if we look more broader, then data quality is a very important issue. Whatever decisions we make, be it political level, policy level, policy decisions, hospital level, hospital manager decisions, also single medical practitioner decisions, we need data. Most of our decisions based on data. And if the data are not accurate or poor quality, then of course the decision also might be poor quality or not perhaps the best ones we can do. And that's why clinical coding audits, or in general data quality checks are very important. And I was invited really to give you an overview of clinical coding audits internationally. My aim is not to cover whole universe, because many countries have different practices, of course, but there are some, let's say, core things which are very similar or even the same throughout the countries when it comes to clinical coding audits. So my intention is to cover cover some of these practices, best practices internationally. We have built this event, this webinar, into or break it down into 4 parts, just to wrap up what has been what I have presented, and then you can clarify or ask questions, and also perhaps some of you need summary in your native language. So we go through this presentation, so that I will give it over to Lily, and then we can discuss. And please, if there is any technical issues, you cannot hear me or I disappear. I mean, the video is not that important as long as you can hear my voice and you can see the slides, so the video doesn't matter. But if there are really technical issues, please let me know. We then can try to switch to phone or try to find out how to proceed. But as far as the connection works, we proceed as in this setting. So I think it's, as far as you are, I mean, as you are closely working with data and coding, you probably know this, but just to remind, what is actually clinical coding? And this is basically a translation of written description of disease or illness, injury, any other reason for seeking care into a code. So you have a narrative label, you have an illness kind of disease, be it acute pain, asthma, fractured rib, etc. And this is the clinical diagnosis or clinical issue you're dealing with. And now the clinical coding is to translate this issue into a code. And as you know, there is WHO ICD International Classification of Diseases version 10, which is the latest. But of course, there are also national modifications, and then this is a bit adjusted into national needs, but for national needs. But in general, you probably, those dealing with coding can understand what these codes mean. And therefore, there is difference between diagnosis and diagnosis code. Diagnosis, as I said, is a narrative label. You describe it, be it staphylococcal meningitis, be it fracture of upper end of ulna, of left hand, for example. This is the narrative, this is a label. And diagnosis code is a combination of letters and numbers when it comes to diagnosis. And you also can use the same definition when it comes to procedures. Procedure itself has description, appendectomy, cholecystectomy, etc. But when you put it in code language or in, like say, machine language, then you have to code it. And then for you, you use different combination of letters and numbers. And diagnosis code is part of classification, which is a hierarchical system of mutually exclusive classes. So you basically can use one code for one medical issue or clinical issue. And here it is important to point out that who is responsible for making the diagnosis and who is responsible for coding the diagnosis. I assume in most countries the diagnosis is responsibility of medical doctors, but the coding might be responsibility of medical doctors or clinical coders or someone else who has knowledge of classifications and coding. And I come back later to this, what is the difference, who does the coding. And those of you who have who really work on coding and do it every day, you probably are familiar with the challenges that you might have faced. That and here's an example of pneumonia. In ICD-10, there are different codes for pneumonia. Is it virus pneumonia? And this J12, for example, has subcodes. Is it bacterial pneumonia? Is it lobar, unspecified aspiration, etc., etc.? For patient, if you say that you have pneumonia, that's enough, I assume, because the patient wants to get healed, wants to get the appropriate treatment. But when it comes to more like clinical part, then of course it is important to specify the diagnosis code as higher level as possible, because also the treatment depends on that, if it is virus pneumonia or virus-caused pneumonia or bacterial pneumonia, you probably choose different way of treat the person or patient. So the lack of specificity is often something what countries or coders face, because reporting, for example, only 3-digit codes, where in case there are also subcodes for this 3-digit code, it is very important to use this most specific code. And in some countries, this 3-digit codes is rejected or denied if someone is using it. And there are more specific subcodes, then these codes are actually not accepted, so that the coder has to really come back to this and specify what is the 4th digit of this code to specify. So this unspecificity is one of the issues what coders can face, and of course this is also related to the risk of for patient safety, because if there is a wrong code, also the treatment can be not relevant, etc. So you can understand the consequences. Now, when we come to clinical coding audit, then what is the aim of the clinical coding audit? First of all, we need to identify, or this allows us to identify the data, the problems in the data. What are the clinical areas or hospitals, departments, specialties, etc., where these the errors occur? What are these areas? But also, what are the sources? Is it lack of education? Is it intentional abuse of the system? Is it just missing or very poor IT solutions, etc.? So this is the one thing what we do with we use a clinical coding audits. The other thing is, of course, to ensure the adherence to primary diagnosis definitions. Again, different countries use the definition for primary diagnosis. It might be different. The WHO classification provides one definition, but it is quite superficial, or it is not so precise. So it might be that in your country you have somehow reworded it or clarified it or made it more specific. So, but clinical coding audit is used to check if the primary diagnosis is coded correctly according to the definition that is used in the country. And also, clinical coding audit allows to assure the compliance with coding rules and conventions. Again, there are very general rules in WHO manual, but depending on countries have come up with much more precise and specific coding rules or coding standards, coding conventions, however, in which country people call it. So this is also one of the aim of clinical coding audit, see if these are, the coding is in compliance with these rules. And as the clinical coding audit goes, and I again get back to this later, usually the medical record is coded, is checked or audited, then you can actually specify the specific medical record or medical records, where the coding is not as expected or is not correct, and so you can actually track whether the hospital or even the medical doctor or the coder, depends who is coding, and see what is lacking, why the coding is poor, and how to intervene. And this is, it also allows you to identify the coding practices which need improving. So clinical coding audit is not really a punishment tool, but it's more trying to identify the problems and then support the improvement via different ways. Is it education? Is it IT solutions? Is it some policy level decisions, development of coding guidelines, etc. So what clinical coding audit is, or what does it focus on, and what does it not focus on? So really, I start from the right part, what it is not. So what clinical coding audit doesn't, it doesn't evaluate the medical diagnostic statement. It doesn't evaluate if the examination of the patient and diagnostics has been okay, or if the treatment of patient has been according to medical protocol. This is this clinical part, and you need a separate, probably also experts or medical doctors for this. But if you come to the left part, then the clinical coding audit is mainly focusing on, as I mentioned already, is the main condition or primary diagnosis. There are different definitions for this. Is it coded according to rules? Are the coded secondary diagnoses and procedures also documented in the medical records? So there might be that you have in your claim data, for example, more codes than recorded in the medical records. So there are some redundant codes. And also, if they are coded, are they coded correctly? Because it's not only about the coding, but it's also about coding correct codes. There might be also the case that what clinical coding audit is focusing is that if the diagnosis and procedures are documented in the medical records, are they coded, or why they are not coded? So this is also finding out the missing codes. And this is really the focus of clinical coding audit, not the part which is related to the treatment of patients or carrying out different diagnostic procedures. You can combine, of course, with this, but usually clinical coding auditors are trained for certain things, and they might not have expertise to do this clinical part. But of course, this can be also combined once you enter or once you get the access to the medical records, so that you combine different focuses when going through the documents. So I will give it over to Lily, to you, so you can sum it up, and if there are questions, we can take questions.
Oke, ya, thank you, Kristiina. Jadi kita membagi segmen ini supaya bagi teman-teman yang mungkin perlu penjelasan lebih lanjut untuk supaya nggak agak kesulitan mengejar apa yang tadi disampaikan oleh Kristiina. Saya ingin mencoba mensummary-kan ya apa yang disampaikan tadi. Jadi seperti yang tadi Kristiina sampaikan, coding klinis itu adalah proses translasi dari deskripsi tertulis tentang penyakit ke dalam kode dari satu sistem klasifikasi tertentu yang akan kita pakai. Nah, sebetulnya kenapa ini menjadi penting, karena lack of specificity tadi ya, kurang spesifiknya kode yang ditulis bisa berdampak terhadap patient safety, karena mungkin pemberian layanannya menjadi tidak spesifik atau tidak akurat dan sebagainya ya. Dan sebetulnya tujuan audit coding klinis itu lebih ke arah codingnya. Jadi area problem dari seputar coding klinisnya sendiri, tentang definisi diagnosis utama, aturan codingnya gitu ya. Sehingga nanti dari hasil audit ini bisa ditentukan apakah perlu training khusus untuk pelatihan dan pengembangan kemampuan coding, atau mungkin area-area dokumen rekam medis yang mungkin perlu diperbaiki juga karena terkait dengan data yang tidak tertangkap dengan baik misalnya gitu ya. Dan fokus dari audit coding sendiri tadi sudah disampaikan, sebetulnya audit coding itu lebih ke arah fokusnya ya, lebih ke arah melihat apakah diagnosisnya udah tepat, kode diagnosisnya udah tepat, apakah diagnosis sekunder dan prosedurnya juga terdokumentasi dengan baik gitu ya, apakah sudah terkode dengan benar, adakah missing code, ada nggak yang tertulis, terdokumentasi tapi malah nggak terkode kayak gitu. Jadi audit coding klinik itu tidak melihat kebenaran perjalanan medisnya, jadi nggak boleh, tidak akan menjudge dari sisi benar nggak ini treatmentnya seperti ini, pengobatan terhadap pasien begini betul tidak, atau protokol sudah patuh terhadap protokol medisnya atau tidak. Jadi kita tidak memasuki ranah audit medik gitu ya, audit medik punya sendiri. Nah, walaupun sebetulnya audit coding itu bisa dikombinasikan juga dengan audit medik, tetapi biasanya auditor coding ini juga terlatihnya khusus ya, hanya ke arah kaidah-kaidah codingnya aja. Jadi kalau dibebani juga dengan audit tentang medis itu meskipun bisa dilakukan secara simultan, tapi kelihatannya akan lebih sulit gitu untuk bisa dilakukan itu. Jadi biasanya audit coding itu memang spesifik ke arah regulasi dan kaidah coding. I think that's all summary-nya ya, dan sekali lagi saya sampaikan kepada peserta bisa nanti menyampaikan menyampaikan pertanyaan melalui kolom chat atau boleh bertanya langsung dengan raise hand. Dan saya ucapkan terima kasih, saya lihat tadi ada Dr. Leo juga dari World Bank, selain Dr. Pandu, terima kasih atas kehadirannya, mungkin nanti kami berikan kesempatan untuk bisa bertanya langsung. Dan boleh dalam bahasa Indonesia, nanti kita akan coba translate-kan. That's all, Kristiina. I will come back to you to continue the presentation.
Okay, good. Okay, let's look at the types of audits. There are different types of audits. First, they can be internal within the hospital, just internal kind of evaluation system, and this stays within the hospital. It can be external, so that an outside hospital institution, be it the Ministry of Health, be it the coding kind of excellence center, outsourced kind of company or something, who comes to hospital to audit. It can be remote, and I get back to this. What does it mean? It can be on-site within the hospital, so that you really dig into the hospital health system or health management system and get into the patient records. It can be manual, or which means that actually you browse the medical records and go through this on-site, but it can be also programmed, so that you use kind of algorithm to find out the errors in the coding. But usually they are all combined. So you basically have the system like this, that you combine programmed, which is often remotely done, because you can, if you have access to the hospital system, it can be programmed and external, manual, and on-site, etc. So this is really how it is arranged, but these are the different types. And what is the difference between programmed and manual? As I mentioned, the programmed audits are based on the specific algorithms. So you don't use really human being doing this and checking the medical records, but you can use programmed IT system when you can catch these kind of cases, like with gender inconsistencies or age inconsistencies. There might be procedure which is not compatible with diagnosis, or some unusual or unexpected code or grouping pattern. So you can really come up with different algorithms. And this, of course, helps you to catch some errors, but programmed is not done by human being. And that's why often countries use manual audit, which means that there is someone, qualified auditor, who does it. And the aim is the same, that you go, the auditor is evaluating the diagnosis and procedure coding, also the quality of medical documentation, because once, as I said, you have this medical record in your hands, it would be waste of time and resources not to check also the general quality of medical documentation. And there also can be combined these manual audits, that they are evaluate the compliance to reimbursement rules or other quality control of administrative data. So that's also what can be done. But again, the main focus is on diagnosis and procedure coding. And of course, when you use manual, or countries who are using manual audits, this is resource consuming, because usually the auditors, and I get back to the auditor qualification, are highly educated experts. With some of them have gone through different certification process, and this is, of course, let's say, considered as a relatively high, how to say, in terms of human resources, the money or the financial resources that goes for auditors are relatively high. And yes, manual audit can be external or internal, but this depends really how it is arranged. What are the requirements for auditor? I cannot provide you a universal, and there doesn't exist a universal, requirements for auditor, because countries have developed different auditor qualification systems, certification systems. But if we put it very broadly, then what are the basics what auditors should know or should do? First, the knowledge and expertise in the application of the rules and conventions of primary classifications, which are used to code. So auditor really has to know the coding standards, and also, of course, the terminology, primary classifications. Auditor has to be able to understand the terminology, what is written in the medical record, and what it actually means, and how it should be coded by using classification systems. Of course, if the audits are related to the secondary classification, to Casemix system, to DRG system, then of course auditors should know or should have knowledge also about the secondary classification system. But the primary focus is on primary classifications, diagnosis and procedures. But this is not enough, because one thing is to dig into medical records and and find out the errors, but the auditors should also be able to report what are the findings. So reporting skills are important, also communication skills, because once you have detected the errors and put it in the report, you also have to communicate to, or provide feedback to the hospitals or to the coders. So both verbal and written communication skills are very important. Also, it's as I said, audits are not a punishment tool, and auditors should be, of course, they have to have a credibility, and they have to be able to explain and justify their decisions. So this is also linked to the knowledge and to expertise on primary classifications and coding standards. They also should be able to abstract information from the medical records or for the hospital IT systems to find this information they need for auditing and for coding purposes. And to provide this, or to guarantee that they are unbiased, they should be independent on clinical coding departments or hospitals they are auditing. So unless it is internal audit, even if it is internal audit, the auditor from, say, surgical department shouldn't audit the medical records of surgical department, but some other department. And if the auditor works like external audit, then he or she shouldn't audit its own hospital. So this credibility and also independence is very, very important to provide really unbiased results. I'm not going through into details about the certification of auditors. As I told, the countries have different programs or certification processes, but not all countries who are providing clinical coding audits don't provide this or don't have the certified auditor system. So if there is no certified auditors in the country, it doesn't mean that you cannot provide clinical coding audit, because then you really rely on auditor skills and expertise and still can conduct audit. For example, I do clinical coding audits myself in Finland. In Finland, there is no certification process, but I have considered as a credible person, and there are a couple of other people who do this, and we are eligible, or we have given mandate to do this. So it doesn't have really fancy complex certification process, but you have to just agree on rules and then accept it. What is the difference between clinician and auditor? Because auditor most often is also someone with clinical background. Like I have medical doctor education, but there can be also other backgrounds, but often they are clinicians both when it comes to background. So clinician has a personal knowledge of the patient, which is not always documented. So clinician goes to the patient, to the ward, and talks to the patient, but what is documented, or what information the clinician gets, might not always be documented, which means that clinician actually has much more information about the patient than the clinical coder or auditor. And that's why some of the information might not be actually documented. Whereas the auditor can only base his audit on what is documented, and therefore the auditor can never have the same information as clinician. And that's why it is very important that the clinician who is treating the patient and gets information during the treatment process, during the hospital stay, needs to code or provide this information in the medical record as precisely as possible, because the auditor doesn't have any other source than this medical document. And that's why, and this is also the difference between clinician and auditor. So here are a couple of principles, and again, the methodology might differ, but now I present mostly how it is done in Nordic countries in North Europe, Finland, Sweden, Norway, how the audits are conducting and what are the main principles. So it is done by two auditors. They do it independently, but simultaneously, which means that they are working together. They might be even in the same room, and they work with the same medical records, but they go through this independently. They can do it from distance if they have access to medical records to hospital system, but they also can sit in the hospital where they can direct access to the medical records. Then also what is usually done is when it comes to Casemix system, if there are countries where the Casemix system is in place, that the audit sample are grouped before the audit and then regrouped after the audit to see if the coding quality has impact on grouping. So it might be that after the audit, some errors have been corrected and you actually can get different grouping results. Which also means that you get different DRGs and different cost weights, and at the end it actually might even have impact on the financing. Audits usually embed relatively small sample compared to the working on routinely database. So when you go to audit, or when you prepare the audit, you should really try to focus on what is the most problematic areas or area, so you can target really this issue, the departments or hospitals which have issues with the coding quality, because as it is manual, you cannot go through thousands of medical records, because it's going to be very, very long in terms of time, but also it's going to be very expensive. And also the audited data is measured against the national standards, which means that if you have clinical standards or clinical guidelines approved in your country, then the coding is measured or evaluated against these standards. And it cannot be really based on the auditor's judgment. So it has to be proved by comparing them to against the national standards. And the key resource for audit is really the competent auditors, because it's the same with competent coders. If they lack expertise or they are not aware of up to date with the latest changes in the classifications, they also then may do mistakes and the results are not actually what are expected. And as I mentioned, the audit is based on the full medical records. I assume also in your country, when the patient is discharged, he or she is provided a discharge summary or discharge letter, but this discharge letter it lacks information what is needed for the auditing. So that's why the audits are, for audits, the medical records, full medical records are used. It can be paper or electronic, it depends on country, it depends on availability. For example, in Finland, we do have access from our office actually to hospital medical records or to hospital IT systems. So of course it goes through different data protection regulations. But so we have access to full medical records, and we can see that the cursus letters, what has happened to patient day by day, etc. So this is what we use for the medical clinical audit. And it might be sometimes some kind of desire that once the electronic medical record is approved and is used, and then the data quality also improves. Yes, it's kind of half truth. That it helps, of course, because there are also all the issues with handwriting probably disappear with the introduction of electronic medical records, but the coding quality as such may not improve by simply implementing the electronic medical records. So this is something that definitely needs to be taken into account, that that's not the key or not the magic of improving the coding quality. And the medical record as such is actually the communication means between healthcare providers. And if medical record is missing information, it might be also great threat to patient safety. And that's why medical records should be really including full information or as complete as possible information about the patient. Because if I, as a medical doctor, for example, miss something, then the next medical doctor who is treating the patient for some other reasons might really miss this information, and it at the end might be really a threat to patient health or even for life. So again, I give it over to Lily. It was a bit longer, so I hope you could catch up and yeah.
Fine. Oke, saya coba summary-kan yang bagian kedua ini. Jadi bahwa tipe audit ini bisa internal, eksternal, dari remote, on-site atau apapun, tergantung kita mau mengadakannya seperti apa gitu ya. Dan bisa dilakukan secara terprogram maupun manual gitu ya. Sebetulnya kalau secara terprogram itu karena yang mengerjakan bukan manusia, jadi harus ada algoritmanya. Nah, algoritmanya harus cukup kuat ya. Apa yang mau dilihat dan bagaimana sumber data mana yang bisa diakses itu memang jadi kalau terprogram ini kendalanya adalah dia harus kuat di algoritma tadi untuk mengecek apa gitu. Tapi yang satu lagi yang manual ini sebetulnya bisa ada benefit lebihnya karena yang melakukan manusia. Jadi seperti kualitas medical documentation itu mungkin lebih bagus dilakukan manual oleh orang. Cuma masalahnya terus juga bisa melihat kepatuhan terhadap aturan, kemudian quality control-nya bisa dilakukan, dan sebetulnya manual audit ini sangat memungkinkan dilakukan sekaligus ya, karena kalau sudah dilakukan verifikasi ataupun dia melihat ini udah pegang dokumennya, kenapa nggak sekaligus dilakukan audit sekalian gitu. Jadi sebetulnya bisa dilakukan secara bersamaan dengan kegiatan yang lain. Cuma masalahnya memang time consuming karena dia butuh dicek satu-satu dan mengandalkan manusia tadi ya. Kemudian juga ada requirement-nya. Kalau auditor itu requirement untuk auditor tidak ada standar yang baku secara internasional. Karena setiap negara itu boleh membuat sistemnya atau ketentuan sendiri-sendiri. Tetapi yang paling penting adalah bahwa auditor ini punya kapasitas ya, punya kemampuan, pengetahuan dan expertise di dalam bidang klasifikasi. Jadi tanda baca, aturan-aturan, pedoman itu harus tahu, terminologi juga ya. Jadi memang harus tahu dan bukan hanya bukan hanya klasifikasi primer seperti ICD 10. Kalau ini udah berkaitan dengan pembiayaan misalnya, kita udah bicara tentang DRG gitu ya, sudah ada secondary classification-nya, yaitu kemampuan tentang Casemix itu seperti apa sih, gimana kita menetapkan Casemix itu supaya tergrouping-nya seperti ini dan seterusnya. Jadi memang harus harus punya kemampuan itu. Kemudian yang ketiga, dia harus mampu juga melaporkan gitu. Misalnya dia menemukan kelainan, kalau tidak bisa mengungkapkan bagaimana, kemudian justifikasinya apa, kenapa dia nyatakan ini tidak tepat, itu kan harus di-compare tadi, ada standarnya, ada regulasinya, nah gitu. Itu dia harus bisa menceritakan ini, sehingga dia harus punya kemampuan verbal dan tertulis untuk dia bisa mengkomunikasikan ini loh, permasalahan dari hasil audit ini gitu. Jadi harus bisa berkomunikasi dengan pihak lain. Ya, kemudian juga harus kredibel tadi. Harus bisa menjelaskan dasarnya apa dia menyatakan ini, audit ini misalnya, ada yang perlu diperbaiki atau dikoreksi. Sehingga dia juga harus punya pengalaman untuk bisa, apa ya, meringkas gitu ya, informasi dalam satu, hasil audit tadi harus diringkas dan dia harus independen. Jadi, tidak boleh terafiliasi dengan rumah sakit supaya, tadi tidak bias ya, pendapatnya dia tidak bias, jadi dia harus independen, baik itu internal maupun eksternal gitu ya. Kalau internal auditor internal pun dia tetap harus ini, dan sertifikasi ya boleh digunakan, tetapi, kalaupun tidak ada sertifikasi menurut, Kristiina bukan menjadi halangan gitu ya, tidak ada sertifikasi pun boleh dilakukan oleh, audit ini boleh tetap dilakukan oleh auditor yang dianggap kompeten dan dia punya, basic skill-nya tadi itu aja. Jadi, di tempatnya Kristiina pun tidak ada, sertifikasi untuk auditor, tapi toh dia harus dipastikan bahwa auditor ini tadi dia kompeten untuk melakukan tugasnya dengan kemampuan itu tadi ya. Kemudian, yang harus dipahami adalah bedanya klinisi dan auditor gitu. Kalau klinisi itu, dokter yang dia menangani pasien langsung, jadi kadang-kadang walaupun nggak ditulis pun, dokternya tahu kondisi pasien seperti apa. Nah bedanya dengan auditor kan auditor nggak lihat, sehingga dia memang hanya boleh, mengaudit itu sesuai apa yang didokumentasikan. Jadi kalau nggak terdokumentasi ya pasti dia, menganggap itu tidak ada, dan ini yang kadang-kadang, bentroknya dengan klinisi itu adalah karena, klinisi merasa begini begini begini, tetapi auditor kan bukan orang yang lihat pasiennya memang. Nah, jadi bagaimana caranya klinisi menggambarkan misalnya layanan dia, sehingga auditor tidak salah menangkap hal ini gitu ya. Kemudian, auditing ini dilakukan secara simultan oleh 2 auditor independen ya. Boleh dua-duanya onsite gitu ya, boleh juga dari jarak jauh kalau, rekam medisnya bisa diakses dari jarak jauh gitu. Dan, sampel audit tadi dari sebelum dan sesudah audit di-grouping lagi untuk melihat, ada nggak dampaknya tadi setelah ternyata diaudit ternyata, kurang nih kayak kayak yang biasanya kami juga lakukan di ICC itu, eee, dari yang, dokumen yang ada ternyata seperti ini grouping-nya. Pas waktu kita lihat, oh ini masih ada missing missing code-nya, begitu missing code-nya dimasukin, oh grouping-nya berubah misalnya. Nah itu juga untuk melihat quality dari coding quality tadi ya, bagaimana pengaruhnya nanti terhadap grouping. Jadi itu kemudian kalau kita punya standar secara nasional, maka audit ini di-compare dengan standar nasional standarnya gimana gitu. Jadi tidak semata-mata berdasarkan pendapat dari si auditor aja kalau memang ada ya standar nasionalnya. Jadi sebetulnya kalau fungsi auditing ini yang paling penting kunci utamanya adalah auditornya kompeten dulu, dia punya kemampuan dan pemahaman yang cukup. Kemudian ternyata sumber data audit itu memang harus full medical record. Nah ini menarik juga ya, saya lihat banyak teman-teman BPJS nih di sini, verifikator. Memang betul baik itu manual atau paper maupun elektronik, dia harus full medical record. Jadi nggak boleh hanya melakukan audit itu berdasarkan resume aja gitu. Karena resume itu memang bisa digunakan tapi tidak bisa sepenuhnya dipercaya karena nanti mungkin ada data-data yang dia lupa masukin di discharge summary atau bagaimana. Electronic medical record pun juga kadang-kadang kalau dia lupa dimasukin ya dia menjadi tadi datanya jadi inakurat gitu. Sehingga memang harus full medical record. Nah, karena dari situ juga nanti bisa ditemukan, dari audit coding ini bisa ditemukan hal-hal yang misalnya tadi missing diagnosis. Missing diagnosis ini berbahaya karena rekam medis itu sebagai sarana komunikasi antar pemberi layanan. Kalau ada yang diagnosis dia missing di situ lupa menulis, itu akan berbahaya untuk patient safety karena mungkin jadi diulangi lagi pemeriksaannya atau bahkan harusnya ada alergi malah dikasih obatnya sehingga ini berbahaya untuk patient safety. Jadi itu nanti salah satu outcome dari audit klinis ini tadi adalah improvement dalam hal penulisan diagnosis dan prosedurnya. I think that's it. Kristiina, I'll get back to you.
Thanks. Okay, we continue. So we take questions and discussion later, right?
Yes.
Okay, good.
You finished it.
Okay, so let's continue. Again, this is kind of universal approach. Country by country, it might differ, but I think in general, this is something what countries are using. Again, especially I'm now representing more than Northern Europe, and I know that these countries use this kind of methodology. So in any audit, I think it doesn't have to be clinical coding audit. It can be any audit. You need different phases, starting with pre-audit phase, then you get to the audit, and then the post-audit. And this logic is also followed in clinical coding audit. The pre-audit phase is very important because if you don't prepare your audit carefully, then you, of course, might fail in conducting the audit on site. So the first thing is related to the selection of sampling, selection of sample or the cases what you're going to audit. And there are different approaches. It can be really random sample from all hospital database. So you use kind of driver or kind of system that you just pick randomly. This can be done if it is programmed, but not recommended when you really want to target some cases or some departments, hospitals which have problems with coding. Then this sampling can be specific to certain medical specialty or DRG. If you know that you might have issues in obstetric department, then you choose or narrow down this sample, the cases by this. Or if there are some DRGs, this is an example of Nordic system. So you pre-select already the cases and then pick randomly from there. It can be also samples of problem areas which have been detected by using by analyzing the database. It can be also, as I told, programmed audit, which is used as a selecting the cases. So you use these specific algorithms and you find out areas where you might have problems. And based on this, you go and make a sample for manual audit. And then it might be follow-up audit of earlier audits. This is also often used because when you do a first-time audit on certain problem areas, then you might be interested if there has been any improvement, and you do follow-up audit after a year or after half a year, depends how burning is this issue. So there are different ways how to do the sampling. And then the sample size, because as I told, usually hospitals, of course, it depends on the hospital size, but there are not tens or hundreds of cases. There might be then thousands or then 100,000 or sometimes perhaps even million cases. So you cannot audit all of them, obviously. And therefore, this statistically significant 5% limit doesn't actually work when it comes to sample size, because even if you had like, I don't know, 10,000 cases in the hospital, then 5% is already quite a big amount in absolute terms. And exactly then, if it is a small hospital, then even this 5% might be really several hundreds of records. So you cannot do it because you might not have enough resources for this. And that's why there are, again, different examples from different countries. For example, in UK, they say that it should be at least 200 medical records, depending on the hospital activity. In Australia, it is generally only 1% of separations or discharges of year. In Finland, for example, when we do it, in university hospital, it is 600, and in other hospitals, 400. But really, these are not really kind of, these are just references. You have to find out your own sample size based on really the issue, and also how big auditors pool you have, because if you have very limited number of auditors, then of course you also limit the number of cases. But it's even more important actually then to target the audit so that you really catch this area which is problematic and which you want, where you want to really try to intervene in terms of education and improving the coding. Then logistics, of course, this might be very one country specific and not relevant to your country, but anyway, you need to schedule the audit. You have to agree with the hospitals what day we will do this or conduct this audit. The other thing is sometimes there are pre-audit questionnaires when you find out different other aspects which might be relevant for the audit, so you need to communicate with the hospital. There might be also a pre-audit meeting, whether before the audit or at the same day. When you go to the hospital, you have a meeting with the involved parties and go through the audit methodology, for example, go through different issues which might need to clarify before the audit. And the hospital needs to prepare the medical records. So this is also one of the things which has to be arranged before you actually go to the audit, to hospital to audit. It might be paper or electronic. It depends really what is available. And then agree the timetable for completion of the audits. And then we come to the audit in the hospitals. And what is the working routine? How many cases you actually are able to go through during one day or during one audit? Here are again just the references from different countries. For example, in Sweden, they target like 80 to 100 cases a day. Cases, I mean medical records. In Australia, it's less. In Finland, we aim 100. In Norway, they use 20 to 30 records for one topic and 10 to 15 minutes per medical record. But these are very, very country specific. And it also depends on for example, how many or how many coding standards, or what is the coding standard situation in the country, because you might know that Australia has this quite a thick book of Australian coding standards. Whereas in Finland, for example, we do not have such a big, document or thick document for this. So it also then whether you need more or less time for auditing. So, but these are just some examples from some countries. And it really, the number you are going to audit, it really depends on the aim of the audit. Is it very targeted on very, very narrow field, or is it more wider to get kind of information? What is the general status? It also depends what kind of audit software is used. So there are a lot of things what has to be taken into account. And based on that, then you can really you agree on the sample size and audit medical records size or numbers. As I told, 2 auditors are used or they conduct the audit. They do it, as I told, independently, but still at the same time. So they go through the medical records. So, and now I can explain how we do it in Finland. When we get the access to the medical records, we have it one computer in one hand, actually, as it in this picture. And on the other side, we have our own laptop with our audit program where we make the notes about, case by case, is the primary diagnosis correct, what is missing, what are missing codes, is there any redundant codes, etc. So we, on one hand, we look at the medical record, and on another laptop, we actually make the notes about this concrete record. And this is, we use a specific program for this so that we can afterwards summarize all this information what we have entered into the program. And once this is done, we compare the results between 2 auditors, because we have gone through the same records, but still the auditors might have different opinions about the correctness of the code. So we clarify these discrepancies. We might go back to the medical record, look at this together and discuss, and then we come up with one solution or one conclusion. So at the end, the hospital gets one assessment or evaluation, which combines the evaluation of 2 auditors. And if there is really issue that 2 auditors cannot come up with a conclusion, they don't agree what other auditor says, then you might need a third opinion, which often we can call it cold standard arbiter, for example, who then is whether from the hospital or some other third auditor, then who basically makes the decision. In my experience and in my life, when I have done audits, we have never needed this golden arbiter, but it might be the case if it is really a complicated case. So this was on site, and once this is done, we get to the post audit phase. Sometimes there are exit interviews, so this is done before the auditors leave the hospital, as there was the the starting interview. We also have exit interview, and we can go through this with the people from the hospital. And there are different things what this interview could cover. We can review the purpose and objectives and methodology of the audit. We can also report the major coding deficiencies. We can agree on coding errors and sources of errors. And in that interview, we can also use this golden arbiter if there are some issues between 2 auditors, which usually is not the case, but if it is, then you can use the third party for this. And we present the general impressions. So it's not about reporting the results, case by case, but it is just providing kind of general view on what on the findings. because it happens all during one day. So it cannot be like a long, I don't know, 2-3 hours kind of workshop, but it is just providing really very general and first impressions about the audit. And then when you have gathered all this information in the computers and you have got the feedback from the hospital during the exit interview, then the auditors start to work with the report, because you have to report back what you have found. And there are, at least in Finland, this is again what we do, and I know this is also what is done in Sweden and Norway. You start with the draft report, and this then contains findings of areas of good practices, also the errors, and this is something what is then discussed with the hospitals, because the hospitals can provide you the feedback and they may not agree with some of your findings, so the auditors might correct the draft report. But basically here already we present really case-by-case issues, if there are errors, which case has what kind of problems. And once this is done and we have discussed with the hospital, or they have been able to read the draft report, then it comes to the final report, and then we once it's finalized, we submit it to the hospitals. And that's basically the process. You end it with report and then provide it to the hospitals. It might be, yeah, and of course the report is really important, because it is not only including the error or list of errors, but it also provides recommendations, because if we do the audit without recommendations and pointing out what needs improvement and what is okay, so it doesn't really, I mean, it's like a dead end, because it doesn't, if there is no follow-up or anything, any recommendation to follow, then it would be just waste of time. So you provide recommendations, and as I mentioned, that if there is really a lot to improve, then you can come back later, half a year, 2 years, and do the same, audit, I mean, in terms of the topic or focus, and see if there has been improvements. I skipped this. What is perhaps relevant to mention is that what do you do with this reports? Of course, you provide it to the hospitals, but there might be also some public interest. What is the coding quality in the hospitals? And here are some examples. For example, in Australia, they don't publish the audit results. In Finland, at the same time, the external audits the results are publicly available. We usually present them in the national Casemix conference or Casemix events, and there are all hospitals which have been audited visible. So this is very transparent and very, and this hospitals are used to this. So it's the way how to do it in Finland. In Norway, the internal audits, and that's all usually the case, that internal audits are not available unless hospital itself wants to publish them, of course. But again, the external audits usually are available. And also Sweden is, in terms of providing data, are very open and very transparent. So the reports with names of the hospitals are available. And Sweden in general is very much using their data. They have very good databases linked with each other, and they provide a lot of different analyses, produce different indicators. But of course, it also all is in compliance with privacy protection, data protection legislation. But it is possible to also to provide data so that you don't break these rules. Yeah, that was about the audit methodology. And again, I give it over to Lily.
Okay, thank you. Well, I had an access to this actually this presentation of yours, but Oke, sebagai sebagai resume untuk yang intermission 3 ini, jadi jumlah sampel yang dipakai untuk audit itu tergantung dari tadi ya jumlah sampel keseluruhan, jumlah dokumen keseluruhan, kemudian tujuannya mau mencari apa dan sebagainya. Jadi jumlah sampel itu sangat tergantung. 5% aja kalau datanya besar, jumlah dokumennya banyak ya 5% aja sudah banyak. Jadi jumlah sampel size itu sangat tergantung dari banyak hal. Kemudian yang juga menarik adalah auditor ini kan ada 2 orang. Jadi gimana kalau misalnya terjadi 2 orangnya tidak saling setuju gitu ya. Ternyata hasilnya kok beda hasil auditnya. Nah, mereka bisa lihat bareng-bareng misalnya gitu, lihat bareng-bareng dokumennya seperti apa sih, mereka diskusi dulu. Kalaupun sampai terakhir mereka tetap tidak sepakat, ada yang namanya golden arbiter. Itu sebagai pihak ketiga lagi gitu yang orang auditor yang ketiga untuk dia menengahi itu tadi, boleh dari dalam rumah sakit ataupun dari luar. Kemudian nanti hasil dari audit itu harus ada, apa namanya, biasanya bersifat general impression aja, jadi secara umum aja, tidak terlalu dokumen per dokumen, dan kemudian dia, mmm menyampaikan juga, error-nya itu apa, kemudian rekomendasinya apa. Jadi harus keluar rekomendasinya apa untuk bisa di-improve oleh, lokal organisasinya, gimana caranya. Dan setelah di-improve tadi boleh aja dia diulangi, diaudit ulang antara 6 bulan sampai 1 tahun gitu. Dan yang saya juga menarik di akhir tadi disebutkan bahwa hasil auditor eksternal tadi kok secara publik bisa di-share gitu, jadi publicly available, orang bisa lihat gitu hasil auditnya di, suatu institusi. Jadi saya kira itu mungkin poin-poinnya yang bisa, saya sampaikan. Is there any more, Kristiina?
There
More
is
presentation?
there is very last part of the upcoding, downcoding, and summary, basically.
Oh, okay. Okay, you may proceed
I can
then.
continue. Okay. Okay, yeah, so this is now the last part of the presentation, just pointing some issues. So once you get the results of the audit, so you might ask, what is a good result? Is it 100% has to be okay? Is it 90%? Is it 50? Are you okay with 20%, etc.? So, but the answer is really that it depends. Because here you can see on the upper side of the slide some results from different countries, mainly from Sweden, and this shows the share of erroneous principal diagnosis. In worst case, it is 30%. In best case, it is 8.3. And this is not really something what we can say that it is bad or it is good, because it depends on how strict coding standards are in the country. If they're the more regulated or the coding in terms of coding standards is, then of course the error rate or the share of the cases with error is most probably higher, whereas the countries with very unregulated or without any coding standards, regardless not taking into account that once WHO is providing, of course, also the error rate is quite small. And there is another example below here, the NHS Wales. He's setting very concrete percentages for accuracy. And here you can see that if the primary diagnosis is more than 90% coded correctly, then it is a good result. And if the secondary diagnosis is more than 80% is coded correctly, it is a let's say good result. And the same with procedures. So this really depends on country, whether you want to set this threshold and say that above this is okay and the below is bad, or you can set kind of intermediate level that this is, you know, not good or bad, but it needs some improvement, etc. So really countries have to figure out what is the appropriate threshold. In Finland, we consider that 5% can be like, if let's say if the coding primary diagnosis is in 5% cases is wrong, then it is still acceptable. but as I told, in Finland we don't have very strict coding guidelines. There is no coding guidelines, or almost no coding guidelines, in addition to what WHO has in their manual, and that's why this 5% is pretty okay. But again, I don't say that this is something what other countries should follow. And just couple of comments on upcoding and gaming. You might be familiar with this. First, upcoding is when the coder is reporting a higher level service or procedure or more complex diagnosis than is supported by medical necessity. And the simple example is that if it is a non-complicated case, but it is coded as complicated, it is done intentionally, then this is then already upcoding. And it has to be systematic and continuous and intentional non-compliance with coding standards. And then we really can talk about the gaming, because people do it consciously. They game with the system because often it is related to the reimbursement. The more complex the patient is, the more money you get. And that's something what happens in some countries. And this really is fraudulent, and in some cases, again, it depends on on countries, on legislation, it might lead to legal or financial penalties, and it needs monitoring, and also you have to detect first this upcoding, and then act, whether via penalties or then via ongoing education. And on right-hand side, I was working with one country in Europe, and we did, and they had implemented Casemix system recently, and we did a pilot audit in 3 hospitals, depending on the level, municipal, rayon, and republic, and then the average. And we find out that after the implementation of the EHS system, and as average, 69% of the cases had redundant secondary diagnosis codes, which means that it was clear upcoding. Of course, you cannot blame them in gaming yet, because this is usually the incentive what Casemix system gives, that the coders are tempted to upcode the cases. But then, of course, it is really important that the coders are trained enough, they have high ethical values, and they have code of conduct to avoid this kind of upcoding. And of course, when it comes to gaming, it is already like intentional and fraudulent, and this has to be combated with too. And the other side is downcoding, which is in opposite to upcoding, and which needs that the coder is reporting a lesser level of diagnosis complexity than the level supported by medical necessity, which means actually that the cost of healthcare provider is carrying out are higher than the coding diagnosis. So basically, hospital is losing money because not everything is coded what should be, and it has influence on actual reimbursement. And downcoding too is often unintentional, and here the reason is that their coder don't have enough skills, or they are incompetent, or they lack incentives. So they basically, let me put it very robust way, they don't care how they do the coding. They don't understand the needs or importance of the coding. And here, of course, it also needs evaluation and monitoring, and then providing the educational opportunities. And this is an example from another country. For example, it's presented a bit different way as the previous slide, but the blue bars show the number of secondary cases before the audit. So when we went to audit, then we, as average, it was 1.3 secondary diagnosis per case. But after the audit, we went through the medical records and added all the additional diagnosis or secondary diagnosis which were missing. and we ended up with 2.6 secondary diagnosis. So basically, as an average, one diagnosis code was missing. And this, of course, also has influence because the grouping would be different with this additional diagnosis. And of course, then when it comes to the reimbursement, then the reimbursement rate or cost weights are also different. So yeah, what are the benefits of clinical coding audits then? First of all, it clarifies the overall level of coding quality, and you can really detect the clinical areas of poor quality, coding quality. Then the feedback of errors provide directed education and clarification. So you can really target the groups of coders or hospitals or departments which need education. And you can then also plan or provide the trainings based on that. And it also a mechanism to prevent recurrence of errors, because once you intervene with these audits, you can really, stop, or at least you hopefully stop that these errors will be continue. And then the benchmarking of results with similar organizations or across hospitals can also provide an input to changes and improvement of coding quality. And that's why it is important to provide, or at least if it is possible and also allowed by legislation, to compare the hospitals and provide this publicly available information, because if the hospitals get only their own feedback, the hospital manager doesn't know how other hospital does and cannot really compare where I am with my results compared to peers. I go through the sanctions very briefly, and then we are soon at the end. As I told, that audits are not really punishment tool, clinical coding audits, and therefore the sanctions are really carefully applied in case there are errors. And usually the sanctions are stated in the legislation or in the contract between the healthcare provider and the insurance company or purchaser organization. And the sanctions policy really depends on whether the hospital is failing just once, or is it unintentional, or it is a systematic and continuous intentional fraudulent way of coding. And you see the difference. So the sanctions has to be therefore really, really careful applied, if at all. And usually it goes as follows, that you start with warning, you say it in the report that there are problems with the coding and we have detecting this and this issues. Then you provide retraining, because this is the first thing, which what should we do? If this doesn't help, and especially when the gaming will continue, then the shaming, okay, the shaming might sounds perhaps, depending on the culture, a bit different, but anyway, you really, by publishing or by somehow pointing out it publicly, this should be something what should have influence on the behavior. And then if this doesn't help, then the punishment at macro level, and then already policy reports responses at macro level. I mean, the punishment at micro level and then macro level. So this is something that can be considered, but of course the aim is not to sanction, but the aim is to improve the coding quality through training and providing educational opportunities. I have some examples from different countries, but I don't go through these just to leave time for discussion. So in summary, I would say, and this is the experience from different countries, that improving data quality in general, not only how to use primary classifications, but improving the data and information quality is a collaborative effort. So it cannot be the problem of purchaser. It cannot be the problem only for hospital or for Ministry of Health or Ministry of Finance or whatever, or whoever. It is a collaborative effort because this is the way how to assure the efficient use of healthcare resources and also improve the patient care and safety. So this is really important. And both purchaser and provider should, but also other institutions who are using the data should play an important role in helping to manage the quality of data. And that's why, as I understood, and also in your country, there are different organizations who are dealing with data quality, and especially with clinical coding audits, and then educating the coders to really provide and then to make effort to improve the coding quality. And often really the coding is somehow linked to the Casemix system or the DRG system, that once we have DRG system, then we should deal with coding quality. That's not the case. I mean, it is important, of course, but actually there are much more broader use of the data. As I started my presentation, there are different levels: policy level, ministry level, or let's say the state level, hospital level, single medical doctor level, who needs the data. It's not about the Casemix system. It's much more where you can use your data. And first of all, it is about the patient safety, but also about the reimbursement, benchmarking, different public health issues, tracking the public health issues, research, etc. So it's much broader, and it shouldn't be narrowed down into the Casemix system. That's why we need the coding quality, but that's much more broader, this focus of the good quality data. So that was it, and you can probably sum up this part, and then we can, well, you will then guide us through the end.
Yeah. Thank you, Kristiina. Jadi terakhir ini tadi memang tentang hasil ya. Ternyata hasilnya juga di sana Kristiina menemukan ada upcoding, gaming gitu ya, dan juga ada downcoding atau undercoding. Jadi memang ternyata ada. Dan yang menarik adalah bisa jadi upcoding ini sifatnya sistematik gitu ya. Sistematik, continuous, dan intentional. Nah, ini yang berbahaya jadi terhadap coding standar gitu. Jadi ini yang disebut gaming tadi ya. Tapi memang juga bahwa ada kemungkinan juga under coding sehingga berdampak kepada kerugian bagi rumah sakit. Dan juga menariknya ada proses tahapan yang saya juga melihat ini sebetulnya sudah ada di undang-undang kita, di regulasi kita, mulai dari warning, kemudian retraining. Nah, yang nggak jelas adalah shaming ya. Kalau di kita tuh nggak jelas nanti harus diumumkan kemana gitu. Kalau di sini shamingnya mungkin dia diumumkan di publik gitu ya. Baru nanti sampai ke punishment gitu. Dan kemudian juga menarik di masing-masing negara punya ketentuan atau sanksi yang beda-beda gitu ya. Ada yang tidak ada hubungannya dengan financial sanction seperti di Australia gitu, tapi ada juga yang dia berkaitan dengan pembayaran pengganti rugian gitu ya. Jadi yang paling penting juga harus diingat bahwa data ini bukan hanya soal reimbursement, banyak sekali kepentingan lain, patient safety, benchmarking, ya komparasi data antar wilayah, kemudian pengambilan keputusan dan kebijakan kesehatan gitu ya, dan seterusnya. Jadi ini memang masalah kebenaran data coding tadi jangan berhenti hanya untuk pembiayaan aja gitu, tapi memang kita harus memikirkan bagaimana bisa sinkron gitu. Selain kita mikirkan biaya, ternyata kan ada kepentingan-kepentingan lain juga yang harus dipikirkan dari ketepatan data. Jadi kalau main-main data hanya untuk mendapatkan pembiayaan lebih, itu dapat menyebabkan bias pada profil data kita sendiri gitu ya. Baik, oke Kristiina, there are so many questions right now, tapi saya ingin memberi kesempatan sebetulnya untuk Dokter Leo dari WHO, bagaimana kalau bertanya langsung aja dok gitu kepada Kristiina, apakah berkenan dok?
Can I stop? Sorry, can I stop sharing?
Oh yes, you may stop share first. Yeah.
Okay.
There is Dr. Leo from WHO. Dr. Leo, would you like to present your questions right? Langsung ke Dokter Kristiina atau bagaimana? Atau kalau belum berkenan, baik, I'll try to read all the questions, right? Yeah, Pak Leo, ada? Would you like to present your questions directly to?
I think he dropped off.
Oh, he dropped off. Okay.
Kayaknya.
Oke, Mas Pandu mau nanya langsung ke Dokter Kristiina, please.
Oh, okay. So thank you very much, Kristiina, for your presentation. Excellent presentation, and also quite useful, I guess, and relevant for us here in Indonesia. I have a couple of questions, but I will give opportunities to others. Quickly is on your initial statement that coding may help indicate or point out issues in quality of care. So my question is how that really work, because again, people who do the clinical coding audit are separate from the medical medical audit, right? So how to leverage, I guess, the potential of using coding to coding audit to clinical coding audit to improve quality of care. And number two is on the use of electronic medical record, because I think the bank has been pointing out that one of the issues in Indonesia is because a lot of the process is done manually, and we are saying that doing digitalization of medical record would lead to improvement, but apparently that's not sufficient. That's not the case. So what would be needed in addition to the digitalization of medical record? That's it, and over to Lily and you.
Thank you. You might answer that right away, or
yeah. Well,
okay.
Perhaps it's easier when we go one by one. Perhaps
Okay.
some others might get the answer already if they have a similar question.
Right.
So I'm not sure I said that the clinical coding audit improves the clinical care, but it improves definitely, not improves, but it helps definitely to find out the potential issues with clinical care, especially when it comes to benchmarking. And when you benchmark or compare different hospitals, and of course you might add also, if you have Casemix system, DRGs, for example, but you might also have length of stay information linked to this information, then you can start to see different patterns. For example, that hospital X uses, this kind of main diagnosis, and the length of stay is, say, 10 days, and the other hospital use the same diagnosis, but the length of stay is, say, 5 days. So there might be differences, and you then can dig into the data and see what these differences or where these differences come from. So it's more like there is no direct way of improving the clinical quality, but by using clinical coding data, you can start, to investigate. And here, this benchmarking is really important, and comparison of hospitals. And as I said, you can link different information to this. What we do, for example, in Finland, for example, we group the data, right? And there are groups like parallel groups with complicated DRGs and not non-complicated DRGs. And if we see that, for example, the complicated DRGs have much shorter length of stay, for example, than non-complicated, then we again start to think that what's the point? Is it the coding quality actually, or is it really the clinical quality? But there is no like a prompt answer when you end up the clinical coding audit that, yeah, there we have issues with clinical care. So it's kind of input for further analysis. I don't know if it answered to your question, but anyway, I take the next one. It is about the digitalization of medical records. Yeah, that's true that only digitalization doesn't help. But once you have digital data or digital medical record, let's say, and you have the supporting infrastructure, IT system, which helps you to derive, different data from this medical record, then you might start to build your kind of internal or built-in controls, which are related to, as I showed you, with inconsistency with age and diagnosis or gender and diagnosis. And this way you can start to really benefit from this digitalization. Whereas if you have only paper records, you cannot do this, or you can, but by using manual kind of check or evaluation. So this is one of the benefit from digitalization or digital medical record. But of course, only this is not enough, because if the coding is poor, then it's most probably is going to poor also when you have medical digital medical record or electronic medical record.
Thank you very much.
Thank you, Kristiina. Okay, there's also Dr. Arkadius. Dr. Arkadius is one of our senior lecturer in coding classification systems coming from West Sumatra. So I would like to have him to deliver the question directly to Kristiina. Silakan, Pak Arkadius. Do you have
Hello,
any
Kristiina.
comment? Okay.
Thank you. The main problem here is most clinicians did not feel the medical records complete enough or sometimes wrong. Also, this is, I believe, more than 90% are like that. The problem arises when the health insurance, the BPJS, make some dispute on the diagnosis. It's really hard to find which one is right because the data is not complete. That's when I was really interested when you said medical record has to be examined thoroughly. And that's what I suggested through the chat room before that. This is where I think the challenge for me, Dr. Lily, and also other parties, we have to expand this understanding to clinicians because this is for their own benefits and our own hospitals. That's what I really want to comment. Thanks a lot for sharing this, Kristiina. I'm really, really happy that I have some basis to tell my friends that this is really not textbook. This is occurring in modern societies. And thank you for Dr. Lily for hosting this very important event. Thank you.
Thank you, Mr.
Thanks.
Arkadius. Yeah, did you grab the question, Kristiina? You understand?
I understood it was more a comment than a question.
Yes.
But
It's comment
yeah,
mostly.
Yeah.
So do you think this is a main issue for us to expand this knowledge? Because in Indonesia, it is considered that this is a medical record practitioner problems. Coding system is not our clinicians' problem. So can you comment on this? Many of our doctors do not care about the coding and clinical coding.
Yeah, it's very familiar to me because I have been working with different countries, and it also probably has kind of cultural and cultural kind of approach or traditions what have been in this country. But of course, the more and more the society is developing, and if the patient come more knowledgeable, and if the patient can, see their medical records, I don't know if it is the case in your country, then if there is missing something, for example, for a patient, that's me as a patient, if I know that I have problem with some, allergy or something else, some more serious disease, and it is not written there, it is first my safety issue, but also, I might even, go to court and argue that this is not, there have been some medical errors or some other issues. So it's probably, it depends although of the society, but this has been something that has been an argument in this region I come from, that if it is not there, it doesn't happen. And you have no other mean of proving that, yeah, patient has this or that, than write it in the medical record. But it is not written there. How you can approve? It's also protecting doctors themselves, because if the patient has really an issue, medical kind of error or treatment error, then the doctor has to also defend himself or herself by saying that, yes, see, I was writing this into medical record, and this is how it was. But if it is not there, no one can say that it actually happened.
There are other questions actually that related to this question. So I would like to ask, how is it going in your country? Do you give certain knowledge about clinical coding to the doctors, clinicians?
Well, now, I am okay. If I say that I'm in Estonia, because I come from Estonia. So in Estonia, they have some, but very minor lectures in the university for the medical students when they introduce ICD-10, and so explain how, the main principles of coding principles. And I have actually been myself lecturer. But this is very little, I would say, and I would, if I were a minister, I would improve this situation much more and provide much more training opportunities. It's the same or similar in Finland. There are not really special trainings for medical doctors. I have, when I was lecturer, I asked the students that when they do their practice or their internship, that if you are struggling, which code you should choose, because in Estonia medical doctors do the coding, and how you find out which is the right way. And they say that, well, I ask nurse, and without any with all respect to nurses, nurses are not responsible for diagnosis, right? So it's good to get some information from nurses, but actually medical doctor is responsible. But I also understand that this is lack of trainings, and this can be really issue. But I know I know that in Australia they have a good educational kind of program, like continuous program for medical doctors, and there are also Germany, for example. But I think it has been considered the coding as kind of secondary thing, which is not my business. And I think this is kind of in many countries, this is attitude you can see, and this is, in my opinion, it's wrong, because the coding at the end matters a lot. And it is, as well as I told in my previous, when we had the previous comment, that it is really also defending the medical doctors, and they should be interested in coding and in correct coding.
Okay. Ya, thank you. Jadi saya lupa meresumekan buat para audiens. Pertanyaannya Dokter Pandu tadi yang pertama adalah bahwa ternyata digitalisasi atau merubah menjadi electronic medical record aja tidak cukup sebetulnya memperbaiki dokumentasi dan coding. Jadi tetap aja manualnya yang juga sangat penting, karena ada hal-hal yang tidak bisa tersupport dengan electronic health record, kecuali kalau manualnya juga bagus, atau tadi digitalisasinya full, jadi dokter tidak nulis sama sekali gitu. Jadi masih tadi ternyata seperti itu ya. Kemudian tapi bahwa digitalisasi rekam medis itu sangat membantu, terutama untuk tadi ya coding audit yang sifatnya terprogram itu bisa otomatis bisa jalan gitu. Tapi di audit manualnya ternyata tetap juga sangat penting gitu ya. Terus yang tadi yang kedua tadi adalah ternyata kenyataannya di negaranya Kristiina juga dokter-dokter ini klinisi tidak punya pelatihan khusus juga gitu, dan isunya sama juga. Kadang-kadang mereka malah nanya ke perawat tentang coding ini. Jadi memang kalau Kristiina sampai bilang kalau saya jadi menterinya saya akan bikin pelatihan lebih bagus deh untuk dokter-dokter gitu. Karena memang juga ini isu yang sama ternyata dengan kita di sini gitu ya. Oke, ini saya lihat Dr. Leo from WHO is already join us again. So Pak Leo, saya akan persilahkan Pak Leo untuk deliver the question right away ke Kristiina.
Terima kasih banyak Bu Lili.
Ya.
Thank you very much Bu Dr. Kristiina and Dr. Lili for inviting me to this very interesting let's say webinar, and I can say that I totally agree with you that it's more or less about the quality of coding. So it's like a diamond in and diamond out, and garbage in and garbage out. So I think we have three issues here. One is already has been answered, but this also happened. Unfortunately, also happened in your country, but in ours it is also an issue that the medical doctors here we don't have any proper lectures in our formal medical educations about the importance of this coding. I believe that the ICD code it's introduced, but only superficially introduced, while the RG system and we have the national one called INASI, which is not properly introduced, and let alone the importance of that. So basically that's the first one, and the second one, may I know, Dr. Kristiina, from the perspective of an experienced auditor, is there any clue or any, let's say, step-by-step formulas based on your experience on how to look into or to detect the possibility of upcoding during an audit process, basically, particularly for those not from medical background. Let's say if you are not a medical doctors, but you're qualified auditors. I believe that to be an auditors, it is actually you have a proper knowledge, specific knowledge on specific terms, but for an auditor, that you said that sometimes it's not necessary to be really a medical doctor to do this, because mostly they are separated audit. So is there, I believe that there will be a challenge, but is there any particular clue on, or steps to detect on upcoding, just based on the data, which in low income or low middle income country, the data is somehow will be incomplete. So the last one is that I think the benchmarking it's a good practice, but unfortunately it will be a bit difficult to exert here, because as you said that most of the report is not published anywhere. So the benchmarking based on other hospital result, it's not quite practical, I guess, here. Okay, that's all from my side.
Yeah.
Thank you very much, Dr. Lili and Dr. Kristiina.
Okay, thank you, Kristiina. Could you respond directly?
So these educational issues we covered already. I totally agree with you that this is an issue, and there is never enough education or trainings for medical doctors, because it's not like one-time approach or one-time effort, because the classification is changing. And I even don't start the discussion about ICD-11, because this needs huge amount of trainings, but I don't want to open this discussion now. So yeah, I agree that definitely this educational aspects are very important, and countries should somehow combat this because providing some lecturers in the curriculum of medical students is definitely not enough.
Dari Finlandia.
So the second question was about how to detect the upcoding. It's poorly really dig into the medical records. Well, I understand the medical records are also poor. Then you basically you actually have very in kind of dilemma, because if the medical record is poor, then of course you probably cannot really also detect the upcoding. But still, if you compare it against the claiming data, which is, for example, sent for reimbursement, and if the claiming data provide more codes, for example, than the medical record, even though it's poor, then this is one way how to actually can spot the upcoding, that there are no compliance between medical record and claims data. So this is one way of doing this. Also, and now we come to the digitalization or digital or electronic medical record. If you have this electronic medical record system, and you can really link it to whether cost data or length of stays data, then you can do what I answered in the beginning of the Q&A session to Mr. Pandu, that you can link this information with different, other variables and compare, and this way really get at least some clue where it can get, where the upcoding can happen. But of course, it means kind of developing a system and algorithm on how to detect this. But the very initial or very first point is that you really have to compare medical record and the claiming data, because otherwise you don't have any other source. And I don't know if this was just a comment or was it a question about that the clinical that the auditors can be someone with not medical background. If this is the case, then of course there should be very clear how to say barrier or threshold how people with non-medical background come to clinical coders. Anyway, they need a training, they need to know terminology, they need to know the coding standards. So without this, I think the person cannot be qualified as a clinical auditor, be the background, whatever it is. And then the benchmarking, I have faced this, that the doctors or the hospitals don't agree to share their data publicly. In 2005, we started in Estonia a similar thing, that we started to collect the Casemix data and diagnosis data, etc., and try to publish it. But of course, we asked the permission from the hospitals first. It was not like kind of we forced them to do, and they didn't agree. And we then hid it into by using password, and it was actually they had access to this, but it was not publicly available, so they could get into this benchmarking, this web page, but it was not publicly available, and it was kind of good starting point. And a couple of years later, they realized that actually there is nothing to hide, and they can allow purchaser organization to publish the data, and since then it's no problem. But if you don't get into this point and you really don't, or hospitals don't agree to publish the data, I think the purchaser organization or ministry or whoever has the data can still do this analysis, and you probably can still compare the data. If you are a purchaser organization, then you should probably, or Ministry of Health or statistical kind of agency, you get this data from the hospitals, and you can do it like in-house, analysis, and then approach different hospitals depending on this benchmarking results, what you see. You don't have to publish them, but you still, I assume, can do the benchmark within, as an organization. And this can be something you can start from to do this comparison, and then approach hospitals and or dig into the data and see what is there. But of course, if it were publicly available, then it would it would have more, let's say, influence, because this publicity or public availability provides, you know, it disciplines more, let's say, the hospitals.
Okay.
I hope
Thank
I
you.
answered the question.
Thank you. Jadi tadi pertanyaan-pertanyaan dari Pak Leo sudah dijawab. Jadi yang pertama tentang education memang belum cukup sih untuk dokter. Kemudian yang kedua, kalau data rekam medisnya buruk ya memang agak susah untuk melakukan audit, tapi bisa di-compare dengan data lain, misalnya length of stay. Kalau kita punya data SIM, ya kita bisa lihat seperti tadi juga pertanyaan Dr. Pandu, bisa mengimprove pelayanan klinis juga dari situ. Jadi misalnya dengan satu diagnosis kok loss-nya panjang sekali, sementara di tempat lain loss-nya dengan diagnosis yang sama loss-nya tidak sama. Nah, ini bisa menjadi sumber investigasi untuk melihat lebih dalam kenapa bisa begini gitu ya. Terus tadi selain pemberian ini tadi electronic medical record tadi memang bisa membantu untuk pemberian delivery of service. Okay, Kristiina, since we have running out of time, but we have still so many questions. What would you like to do? Shall we give more question to you, or how?
Well, it's up to you. If the participants have reserved these 2 hours and everyone have some other commitments, we can stop here. I have time. It's Saturday. It's Friday. Day off, so it's okay. We can continue, but it's really up to you. Or we can, if you can summarize them somehow. And so
we we try several. That is important question, right? Let me ask some of these. Yeah, some of the questions. Oke, ini ada Dr. Maya Hardiana. Ya, Dr. Maya Hardiana is asking, what makes you interested to be a doctor in this coding field? Did you still being a clinician, or you just fully as auditor or something else? And the second question, how to improve your ability to translate the doctor's diagnosis into a code and the regulation according to the classification system, only based on summary, discharge summary. How could you translate discharge summary into coding? And then the third one is, how long does it take to get a data to audit? And is it duration? The duration, is it 1 year of the previous claim, or how many the range of data that is taken as a sample? Thank you. That's the third question.
Yeah, so really my background is medical doctor, but and it was my dream to become a medical doctor, especially a sports doctor, because this was for me somehow very attractive. But you know, sometimes your dreams don't come true, right? So you have to make decisions and you have to change your mindset. And that was the case with me, because of the private reasons, family reasons. I was traveling quite a lot and we lived in different countries. So it was after I graduated, so it was very difficult to, you know, adapt to this new country and new language. And so I had to choose. And then I choose this administrative, you know, part or management part of the healthcare. And that's how I became, you know, work with the data and primary classifications and audit, and actually Casemix system, which is the main issue I'm dealing with right now. So the clinical being an auditor is part of my commitments or responsibilities, but the much bigger part of my daily work is related to development or maintenance of Nordic system. So my clinical background is useful. I can benefit from this, but I'm not working as a clinician right now, even though I read hundreds of medical records, and I also, of course, try to keep up in in different developments in medicine, but or healthcare in general. But of course, it is not. I better don't treat the patients. I can treat my kids, but not patients in the hospital. So the second question it was about how to use the discharge for coding, right? Or was this the
yeah, is it enough? Yeah, how to translate?
Well, it's well,
as
I said, it's not enough. It's minimum what you can use, but if the medical records, I mean, if patient, for example, has had, I don't know, bleeding, for example, and this is only written in the medical record, like, I don't know, bleeding of gastrointestinal tract, for example, but you cannot find information about this in the discharge letter. This means that you actually cannot code it because discharge letter doesn't have this information. Or if the patient has, I don't know, high blood sugar or high blood pressure, and this is not mentioned in the discharge letter, then you might miss this information and this is not coded. So the very strong recommendation is to use full medical record. But I also understood that medical record might also sometimes missing information. So that's then another issue, another problem why medical records are so poor. But still, as a discharge letter for coding and auditing is not enough, in my opinion. Then we never use it for this. Yes, we read the discharge letter during the audit, but we also go through the full medical record to find the medication, to find different procedures what patient has been done, to read the anamnesis, etc. So this all should be written in the medical record. And based on this, you can actually come up with codes and with information what you need for coding and also for auditing. And the third question, how long does it take to become an auditor? This really depends on the country. As I told, in Finland, there is no accreditation or certification of auditors. There is no formal training program. So I started my career, if I can put it this way, with a senior auditor. We did it together in the beginning, and we developed, or actually they had a kind of methodology. And this was the way how I started to work as an auditor. But there are countries, especially UK, also Australia, Ireland, and Germany, different countries who have really curriculum for coders, clinical coders, but also for auditors. And there are different criteria. Once you go through the curriculum, pass your exams, it takes 2, 3, perhaps sometimes 4 or 5 years when you have to redo your course or give the exam. So this, I don't have one answer because it really depends on the country.
How about the sample? How long the duration of the audit for 1 year claim? I mean, 1 year before, or is it every year or every 6 months or something like that?
When we conduct audits?
The clinical audit is conducted every year, once a year, or every 6 months?
Yeah, well, in Finland, we try to audit every hospital at least once a year, but this is quite a high, let's say, burden. Because we have very limited pool of auditors. This rhythm or how you do this, it really, again, depends. If it is a small sample on very narrow area and you find the results are okay, then you actually don't need to go back to this hospital on that issues anymore. But we usually do it, once a year, but every year we have different topics. Like this year, we have 3 locations of cancer, which are under our focus. And we focus on this in all hospitals, and this makes it also, the comparison possible, because if we choose one topic in one hospital, other topic in other hospital, then we cannot compare. So our approach is to use one topic for all hospitals, which allows us also to compare. And hospitals are very interested in this because they can see how they do compare to the peers.
Oke, ya, mudah-mudahan dipahami Dokter Maya. Jadi yang pertama beliau sudah tidak klinisi lagi ya, kecuali untuk anaknya dia mau masih, tapi dia tidak mengobati lagi. Cuma dia menganggap bahwa background klinisinya ini sangat membantu fungsi dia sebagai auditor. Kemudian yang kedua, tidak ada sertifikasi auditor ya. Jadi tadi menjawab pertanyaannya Bu Isma juga, jadi auditor coding itu tidak ada sertifikasinya, hanya dianggap kompeten saja dulu gitu. Tinggal masing-masing negara membuat kriteria kompetensi gitu ya. Yang ketiga tadi apa tadi yang terakhir? Tiap tahun ada audit klinik, tapi masing-masing tidak semua rumah sakit akan mengalami pengulangan, dan yang kedua adalah mengambil tema tertentu sehingga bisa dibandingkan gitu antar rumah sakit dengan tema yang sama. Tadi pertanyaan kedua sudah dijawab semua ya, Dokter Maya ya? Oke, there are two other questions left. Yang pertama Pak Sigit. Pak Sigit mau tanya langsung apa mau dibacain aja? Halo Pak Sigit, masih ada kah? Oke, kita baca, dibacain aja ya. Oke, so this is the question from Mr. Sigit Prabowo. What is the most difficult obstacle in the Casemix system there in determining the correct quality of coding and according to applicable standards or regulation? Who or what profession is allowed or competent to carry out the coding? Is there any certain profession? Yeah. And the second is, when compared to Casemix system in Indonesia, what are the similarities and differences, as well as whether the medical record documentation is full electronic in your country, or is it still using paper document? Thank you.
I start from the latter.
Mm-hmm.
So again, in Estonia, actually, the Casemix, the electronic claim management system was introduced in 2001. So it was like almost 20 years ago. And since then, everything is electronic. But of course, there are also paper, you can print out the paper medical record. So in these terms, it exists, but basically all data are entered in the hospital electronically. So if this was the question. And it is similar in Finland. And sorry, I missed the first question. I was focused on the second question.
Who or what profession is allowed to do the coding? Is it?
Yeah, right. So it is kind of tradition in Nordic countries. I mean, Finland, Sweden, Norway, also Estonia, also Latvia. When you go down to the south, that the medical doctors do the coding. So there is no like clinical coder profession in these countries. There are some initiatives in Sweden, for example, where they educated, or this program is still going on, clinical coders. But to switch from this medical, from coding of medical doctors to clinician, to clinical coders, it needs, of course, some efforts, because first you have to develop the specific programs for the clinical coders and set the criteria, etc. So this is probably also the reason why it has not happened in these countries. And the other thing is that medical doctors feel that this is, they feel the responsibility. They might not be happy that someone else is taking this responsibility. So it's also about setting the mindset question, I think, in these countries.
Oke, Pak Sigit, tadi sudah dijawab ya pertanyaan itu. Kemudian ini saya melihat kalau dari peserta ada Pak Rocky. Pak Rocky mau bertanya, Pak, dari Ministry of Finance ini.
Thank you for the opportunity, Ibu Lily. Thank you for your presentation, Dr. Kristiina. Maybe this is in maybe in international practices or best practice. Auditor coding. It is conducting in or implementing in all the hospital, each hospital, or maybe we have some units or some institution to have that responsibility, maybe under the Ministry of Health or maybe under the National Social Security Agency. And because currently we have in Indonesia, I heard that Ministry of Health will formulating Indonesian DRGs. So I mean the implementation of the National Social Security in Indonesia is for about 4 until 5 years. The result of if we already have the auditor task, it will be helpful to formulating in our current that is right now. So my point of my question is, the first one is the international practice or best practice, which institution or should do the auditor coding, or and maybe and ideally each of hospital or each of health provider have an auditor function. And the second thing, and maybe you can give us your experience about the maybe developing the coding itself into the good one, that the auditor coding result will helpful to give an advice to the developing of the coding. Thank you.
Okay.
Yeah. So about the institution who should do the audits, I mean, in very general saying, usually the purchaser organization who is actually getting the data for purchasing is not conducting the clinical coding audit, but this is not like strict rule, because it also depends on the capacity and also the competency. Often people working in purchaser organization have this knowledge about the primary classification. So basically you have people there already, and this is not against any kind of conventional rule that they shouldn't act as an auditor. And that's the case in many countries, that the purchaser organization does also the audits. In Finland, for example, where I'm working in National DRG Center or National Casemix Center. We are not the purchaser organization. We are just maintaining and developing the DRG system in Finland. And that is a natural kind of way, also providing and also conducting the clinical coding audits, because this is very much related to the data quality. In Germany also there is another institution which is owned by hospitals and purchaser organizations. So it's a mix of two parties, and there is this capacity of conducting the clinical coding audits. So there are different examples from different countries, and basically wherever you have this capacity, I think it can be just formalized that this is this audit, I don't know, unit or section who then does this audits. And it can be also within the hospitals, as I showed you, that there are internal audits also available, and it can be done within the hospital. And again, you just need a pool of auditors or auditors who do it without being biased. They cannot audit their own department, but they can audit some other department in the hospital. So this is not in summary very strict. And when I think most important is to provide this audit and the deal with data quality, rather to get stuck with this formalities and administrative and kind of different issues, because if you don't do anything, then you cannot actually know what is the data quality level, and you cannot improve it either. Your second question about the developing the coding, I mean, this is another 2-hour workshop or webinar. It starts, of course, from the education of the students and medical doctors, and then the update of primary classifications, developing the coding standards. And this has to be consistent. It has to be routine work. And of course, for this you need capacity, institutional capacity, who does it. And then the other side is this auditing, improving, detecting the coding issues, monitoring it, also data mining, data analysis. So I don't go into the details. There are very different elements which all improve the coding.
Okay, yeah, thank you. Maybe the last question, but I see this ada Bapak Syafruddin dari P2JK. Apakah Bapak ingin memberikan pertanyaan langsung kepada Kristiina atau bagaimana? Kami persilahkan kalau berkenan. Oke, no? Baik, kalau gitu ada pertanyaan dari Dokter Esti. How to, excuse me first. Yeah, how to differentiate the primary diagnosis through the second differentiate between between the primary and secondary diagnosis. That's the question from Dr. Esti. Only by discharge summary.
And this is actually it starts first how the primary diagnosis is defined in your country. Is it the diagnosis which is responsible for most of the resources used during the hospital stay, or is it the diagnosis of admission, or what is this? So as long as you have definition for primary diagnosis, and then the rest are secondary diagnosis, only then you can actually check from the medical record whether this what is written as primary diagnosis responds to this or to this definition. And usually the discharge letter is not enough, because at least this is my assumption and experience, that you really have to go through the medical record and see what was actually the reason why the patient was hospitalized, and was there any development of other disease or injury or any other issue during the hospital stay. Most of the cases, the patient arrives with some medical issue, and this is treated, and that's the main diagnosis without any problem. But in some cases, the patient is admitted with one problem, and then during the stay, there is another issue which is developing, and then you have to start to think, what is now the primary diagnosis? And here really the definition, and this can be on national level different what WHO is providing. The definition of primary diagnosis is really important. I don't know how it is in your country. Is it defined or is it agreed? If not, then of course it is very difficult to claim that the primary diagnosis is wrong, because there is no rule or no definition for this.
Ya, jadi singkatnya Bu Esti, memang ada definisi itu aja sih nanti, karena data panjang sekali, banyak hal yang harus dipertimbangkan dalam memilih diagnosis. Jadi nggak boleh bingung sebetulnya, berpatokan pada definisi yang jelas tentang diagnosis gitu aja. Okay, as the closing question, before that I would like to remind semua peserta pelatihan, you may fill in our link of absency to get your certificate. Yeah, okay. The last and closing section, question is from Ibu Novianti. I would like to know, in Estonia, the scheme of payment, is it only by DRG, or you combine it with other scheme as if global budget or something? And the second question, did you use the audit result as a part of hospital accreditation? Thank you.
Yeah, the question to the answer to the second question is no, it is not used, because it is in Estonia they don't have this. I mean, if you used it, then you should do the audits, regularly to all hospitals, and it wouldn't be appropriate if some hospitals, who have been audited, or this is taken into account in accreditation, and others who haven't, they don't use this information. So the answer is no. And the first question about Estonia and combination of our reimbursement schemes. In Estonia, in inpatient settings, in hospital care, the DRGs are combined with fee-for-service payment mechanisms. So there is no global budget used. And why it is combined with fee-for-service is purely historical reason, because before implementing DRGs, Estonia, the main payment mechanism for hospitals was fee-for-service payment, and as you know, fee-for-service gives kind of perverse incentives, and to balance this, the DRG was added, but not 100%, but just partially. So this is the combination of two payment methods.
Okay, is there any regulation? I mean, is there any differences? I mean, which part is paid by fee-for-service and which part is DRGs?
Actually, there are we call it outliers or exemptions, like chemotherapy or psychiatric care, rehab, for example, which are paid 100% fee-for-service. But all other acute care cases, this is the combination on case level or patient level. So this is the combination, and again, this can be explained, of course, much more, longer.
Yeah,
but this happens on case level. So one claim gets the DRG share and fee-for-service share, because claim has
if possible,
it is, and that's actually the benefit of electronic data system, because you can use this, also calculating the reimbursement rate with that.
Oke, jadi Bu Novianti dia dikombinasi, jadi ada pembayaran dengan DRG, ada yang fee for service gitu. Tapi memang ada ketentuan-ketentuan lain yang tidak bisa dijelaskan di sini. Dan hasil audit tidak digunakan untuk akreditasi karena akan sulit ya. Tadi juga sudah disampaikan Kristiina, dia auditnya aja belum tentu bisa setahun sekali karena begitu banyak rumah sakit dan begitu banyak yang akan dilakukan. Baik, karena ini waktu yang sangat because there's time is very limited, and we would like to thank you, Kristiina, for your time here, and I'm so glad that there are so many nice responses. Buat Bapak Ibu yang belum berkesempatan untuk bertanya langsung, mungkin bisa melalui panitia kami nanti ya dari admin, kita akan sampaikan kepada beliau karena kami masih akan terus komunikasi dengan Kristiina, and hopefully we can do some other topic or issue ya, Kristiina, we can elaborate something in the future. Dan silahkan Bapak Ibu kalau ingin maksudnya mengusulkan kira-kira apa yang bisa kita elaborasikan, barangkali nanti kesempatannya akan ada. Saya terima kasih sekali lagi atas kehadiran dan partisipasinya semua. Mudah-mudahan apa yang kita bahas di sini bisa bermanfaat. Nanti ada resume yang akan saya bagikan melalui website kami ya, resume dari diskusi kali ini. Dan buat Bapak Ibu yang ketinggalan ini, you may follow our YouTube channel because we are also live streaming there in YouTube, and you can access this if you missed our Zoom meeting right now. Thanks again, Kristiina. Have a good day. Hopefully, we look forward to see you again. Thank you.
Thank you very much. Terima kasih, and have a nice weekend and enjoy your weekend and with your close friends and family.
You're
Thanks a lot.
So nice. You can say terima kasih. Thank you.
That was the second word I know, so I will learn more for next time.
Oh yeah, I haven't. So next time I will speak in Finnish, right?
Good. Well, deal.
Okay. Thank you,
Thanks a lot.
Pak Pandu, Pak Leo dari WHO dan dari World Bank. Kemudian saya lihat ada P2JK, teman-teman dari BPJS Kesehatan semuanya. Aduh, saya senang sekali. Sampai jumpa lagi pada kesempatan lain. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera. Om Santi Santi Santi. Bye.
Bye.
Bye everyone. Thank you.
Thank you very much, Kristiina.
Okay. Thank you, Pak Pandu.